All right, today we're going tactical. We're diving deep into a microscopic war zone, the human peritoneal cavity. For patients on peritoneal dialysis, this delicate internal membrane isn't just a filter, it becomes a constant battleground. This is our clinical masterclass on CAPD-related peritonitis, and we're going to frame it exactly as it is, a high-stakes campaign fought right inside the peritoneum.
So, here's our battle plan. We're going to march through 6 key theaters of this conflict. First, we have to understand the battlefield itself, the compromised peritoneum. Then, we'll get into the intelligence-gathering phase of diagnostics. After that, we'll profile the microbial invaders, know your enemy. Then we'll cover the therapeutic counteroffensives for both adults and kids. And finally, we'll zoom out to look at the long war, the absolutely crucial strategies for prevention and the lasting consequences of every single battle. Okay, let's set the stage. The peritoneum is so much more than just a passive filter for dialysis. It's an active, immunologically dynamic organ. But for our patients, it's a perpetually compromised frontier. It really is an immunological battlefield where the body's defenses are under constant siege. And here's the fundamental conflict, right? PD is a life-sustaining therapy. But the very fluid we use, the dialysate, it's not exactly friendly to the local environment. It's hyperosmolar, it's acidic, and it creates this state of chronic, low-grade inflammation that just hammers the local immune cells. One source I read described it perfectly as iatrogenic immunological sabotage. Think about that. The treatment itself is weakening the very defenses that are meant to protect against its most common and dangerous complication. So, how do the invaders actually breach this sterile space? Well, there are 4 main pathways. The most common, by a long shot, is the intraluminal route. We're talking simple touch contamination when connecting the dialysate bags. The second is periluminal, where bugs from an infected exit site decide to migrate right along the catheter. Then you have the less common but way more severe transmural invasion. That's bacteria crossing over from the gut, maybe after a procedure like a colonoscopy. And finally, in rare cases, you can get hematogenous seeding from a totally different infection somewhere else in the body. Right. The enemy is now inside the gates. The battle immediately shifts to diagnostics. This is our intelligence gathering phase, and it is absolutely critical. You can't launch a targeted strike if you have no idea who or what you're fighting. Rapid, accurate identification of the pathogen, it's everything. The International Society for Peritoneal Dialysis, the ISPD, has basically standardized the rules of engagement here. To make a diagnosis, you need at least 2 of these 3 criteria. 1, clinical features like abdominal pain or that classic telltale sign of cloudy effluent. 2, a lab analysis showing a white blood cell count over 100, with more than half of them being neutrophils. And 3, a positive culture. Now here's the key. This means you can, and should, make the diagnosis and start treatment before you even get the culture results back. Just remember, for an accurate cell count, you need at least a 2-hour dwell time. Now this number, less than 15%, this is a huge quality benchmark for any PD program. This is the target rate for culture-negative peritonitis. That's where you have the clinical signs, but you fail to actually grow the organism in the lab. If your program's rate is higher than this, it is a major red flag. It points to a systemic problem in your diagnostic process that you need to investigate, like yesterday. So how do you make sure you stay below that 15% target? You follow the gold standard for processing. That's how. First, you aseptically collect a pretty large volume. We're talking 50 to 100 milliliters from the very first cloudy bag you see. Then, you concentrate that sample by spinning it down in a centrifuge to get a pellet. And finally, you take that concentrated pellet of cells and bacteria and you inoculate it directly into blood culture bottles. This method is the best practice, and it just dramatically boosts your chances of identifying the enemy. Okay, we've gathered our intel. Now it's time to profile the enemy. See, the microbial landscape of peritonitis isn't random at all. It follows very predictable patterns. Knowing the usual suspects and how they behave is absolutely essential for planning your initial therapeutic assault. And this is what that landscape usually looks like. The battlefield is overwhelmingly dominated by gram-positive organisms. They account for over 80% of cases. And these are usually your typical skin flora, like staph, that get introduced by touch contamination. Gram-negatives and the more unusual fungal or polymicrobial infections make up the rest of the pie. But listen, not all invaders are created equal. There's a huge difference in severity. On one hand, you've got organisms like Staphylococcus epidermidis. They're common, and they often cause a milder illness that you can manage as an outpatient. On the other hand, an infection with Staphylococcus aureus or a gram-negative rod like Pseudomonas, that is a much, much more serious fight. It often requires hospitalization and carries a far worse prognosis. And if you see a mix of gut bacteria, that is a massive red flag for an intra-abdominal catastrophe. All right, with our intel gathered and the enemy profiled, it is time to launch the counter-offensive. Getting effective antimicrobial therapy started and started fast is absolutely crucial to prevent irreversible damage to that peritoneal membrane. So the standard first-line attack is a powerful 1-2 punch. The route is intraperitoneal, or IP. That means we're putting the antibiotics directly into the dialysate to get the highest possible concentration right at the site of the infection. The combination covers both major threats, vancomycin for the gram-positives and ceftazidime for the gram-negatives, including that dreaded Pseudomonas. This is our initial broadside attack, and then we refine it once we get the culture results back.
Okay, let's put this into practice with a case. We've got a 67-year-old man. He has a colonoscopy. 2 days later, bam, severe peritonitis. The cultures come back, growing multiple enteric organisms. But here's the problem. Despite 5 days on the correct targeted antibiotics, he's not getting better. His effluent is still cloudy. So what do we call this? And, more importantly, what is the one thing that absolutely must happen next?
This is a textbook case of refractory peritonitis. The definition is right there. Failure of the effluent to clear after 5 days of appropriate antibiotics. And here is the non-negotiable critical takeaway. Continuing with antibiotics alone is pointless. The only effective move is immediate PD catheter removal, period. That catheter is acting as a foreign body, it's harboring a biofilm, and that makes eradication impossible. This case also shines a big, bright light on a preventable error. Guidelines clearly recommend antibiotic prophylaxis before a colonoscopy, and that step was missed here. Now let's shift our focus to our pediatric patients. Managing peritonitis in children, it requires a whole different set of considerations. The goal isn't just to cure the infection, it's to do it while minimizing any drug toxicity and preserving the long-term health of the peritoneum, a membrane these kids might need to rely on for decades. Exactly. Because we want to avoid potentially toxic drugs, pediatric therapy uses a risk-stratified approach. For uncomplicated cases, cloudy fluid but the kid feels okay, no fever, no severe pain, the standard is a combination of cefazolin and ceftazidime. But for severe peritonitis, or in kids who have risk factors for resistant bugs, the protocol gets escalated to that more aggressive combination of vancomycin and ceftazidime, just like the adult regimen. It's a really delicate balance between efficacy and long-term safety. Okay, case number 2. A 7-year-old girl develops peritonitis. But this time, the lab cultures a very unusual organism, Pasteurella multicida. When the team asks more questions, the family mentions their pet cat often plays near her dialysis machine. What critical clue does this specific bacterium give us about the source of her infection? This finding teaches us a critical lesson. See, Pasteurella is not a human skin bug. It's a normal resident in the mouths of cats and dogs. Finding it in a peritonitis sample is what we call pathognomonic. It's a uniquely characteristic sign that points directly to zoonotic transmission from a pet. This proves that the source of contamination isn't always a lapse in hand washing. You have to investigate the entire home environment. It totally validates the recent ISPD guideline changes that say, hey, maybe keep pets out of the room during exchanges. So far, we've really been in the trenches, focused on the acute battle. But now we have to pull back and consider the long war. Because the ultimate goal isn't just to treat peritonitis, it's to prevent it from ever happening. And that's because even a cured infection leaves behind lasting scars that can have absolutely devastating consequences down the road. Look, the amazing decline we've seen in peritonitis rates over the years isn't because of some single magic bullet. It's the result of what one source beautifully calls the aggregation of marginal gains. It's a comprehensive, systems-based approach. It includes everything from pre-op antibiotics and advanced flush-before-fill tubing to daily topical creams at the exit site, procedural prophylaxis, and maybe most importantly, rigorous and continuous patient and caregiver education.
And this is why prevention is king. A single episode of peritonitis can set off this devastating cascade of long-term problems. It is the #1 cause of technique failure, forcing a patient off their home therapy and onto in-center hemodialysis. Each episode adds more scarring, more fibrosis, which eventually leads to ultrafiltration failure. The membrane just can't pull off enough fluid anymore. And the horrific end stage of this whole process is encapsulating peritoneal sclerosis, or EPS, a catastrophic condition where the intestines literally get encased in a fibrous cocoon.
Let's just put a hard number on that to let it sink in. A large Dutch study found a really stark reality. Peritonitis is the single biggest modifiable cause of technique failure. It's responsible for 1 out of every 5 patients being forced to abandon peritoneal dialysis. This one complication is the primary driver that takes patients away from the independence of their home-based therapy. And this really forces us to reframe how we even think about this disease. Peritonitis isn't just a series of separate, recoverable illnesses. As one source so powerfully concludes, each episode, even when cured, inflicts a degree of irreversible harm, increasing the stepwise probability of permanent membrane damage, technique failure, and ultimately mortality. That single thought elevates the mission of prevention from just avoiding an infection to preserving the very viability of a life-sustaining therapy.